If someone stops a GLP-1 receptor agonist or one of these GLP drugs, what tends to change first?
What generally happens first is that people start to feel hungrier.
Hello, Dr. Verma here, and welcome to The Six Health, where medicine's most important questions are explored through clear conversations with people helping shape what comes next. Today, as part of our GLP-1 MasterClass, I'm delighted to be joined by Professor Jennifer Green, a leading expert in diabetes, metabolism, and cardiovascular medicine. Welcome, Professor Green. It's really wonderful to have you with us today.
Thank you for having me. I'm really looking forward to the conversation.
Are we just talking about sort of weight rebound, or is there something occurring that is metabolically much deeper?
Well, that's a great question. And these drugs work in very interesting ways. And part of the way that these medications work is they actually work in the brain. And for example, I've had people tell me that when they start taking a GLP-1 receptor agonist, that was the first time that they weren't thinking about eating all the time. So the drugs start working right away in the brain to, in many people, suppress appetite, reduce hunger, for example, reduce what some people call food noise. And when you stop the medication, that effect goes away. Now, some of these medicines have a fairly long duration of action, so it may take a couple weeks, 3 weeks before that effect in the brain it has completely disappeared. But what generally happens first is that people start to feel hungrier. This food signaling in the brain returns to probably what it was before they started taking the medication. So that happens first. And then when people understandably resume their previous eating habits, eating more in response to that, then we see a lot of changes. And there can be a lot of changes in what we consider to be cardiovascular risk factors like blood pressure, lipids, blood sugar, for example, that can accompany that over time.
So it's not just the weight that goes back up, or I guess the hunger signal, as you said, but along with that, some of the other cardiovascular risk factors seem to sort of creep back up. Is that what you're saying?
When people stop taking GLP-1 receptor agonists or similar medications, they tend to regain, on average, a little under a pound a month or 0.4 kilos per month. And then along with that, we again see this deterioration in control of things like blood pressure, blood sugar, for example, if they have diabetes, so that there's this gradual creep up towards baseline. So they tend to return to their pre-medication state. I guess the good news is we don't think that people are any worse off than they were before they started taking the medications, but the gains that they had experienced while taking the medication are lost, probably within a year and a half or so off of medication. It appears that people really over time tend to return to their physical health, their physical state that they were living at before they started taking the medication. So it's their underlying sort of usual state. It's the underlying disease that essentially is excess weight and or obesity that is essentially recurring off of the medication, as we see with many diseases and medical conditions.
Right. But would you say, Dr. Green, that one of the biggest misunderstandings is that stopping a GLP-1 means that the treatment failed?
You know, that is a very common misconception. When we think about other chronic conditions, like, for example, I'm an endocrinologist. So when I think about treating a condition like diabetes or hypertension or high cholesterol, for example,
right,
we understand that people will need to take medications to manage those conditions lifelong, and overweight and obesity are no different. So if you take a medication that works while you're on it, that's a success story. if the condition recurs or becomes uncontrolled when you stop it, I don't think that that means the treatment failed. It's really an expected side effect of stopping an effective medication for that condition. So, and as you know, overweight and obesity are very metabolically complex conditions. Each of our bodies has its preferred weight set point, and along with that, a certain degree of appetite, insulin resistance, inflammation. Our body has its own unique biology, and it will revert to that, I think, when medications like GLP-1 receptor agonists are stopped.
Really well said. And, something that I've started gaining a lot of appreciation for is the fragile patient's perspective often, and what they feel when weight returns. And I certainly want you to weigh in on this. This is an area of your expertise. You probably have lots and lots of people that you treat, and you've had these conversations. What is your perspective from a patient's standpoint? What do they feel when the weight returns?
Well, first, I do want to say that I completely understand. I think it's a natural human desire to want to not have to take medicine forever. I get it. I understand. The problem is when you stop a medication that has allowed you to really successfully lose a lot of weight and improve control of your diabetes, for example, people do feel like they've lost control again. Maybe not immediately. But again, I think generally within a few weeks of stopping a GLP-1 receptor agonist, people will kind of feel their usual hunger, their appetite return. And it's important for people to understand that this result of coming off of a GLP-1 receptor agonist really has nothing to do with willpower. Again, it's our body's set point. It's our body's preferred weight that we're all dealing with. This is, again, not about willpower or making the right choices. It's about biology. And I think it's very helpful for both individuals with these conditions and their clinicians to understand that and be able to talk about it comfortably.
I think that's such an important message, right? Empowering people and recognizing that this is not failure on their part. And recognizing that this is biology and recognizing that this is their natural set point, whether it's healthy or unhealthy is a different story. I think is a core message if we're going to win the war against overweight and obesity. So, really, as I was hearing you speak, Dr. Green, it's clear that, you stop these medications. These are chronic medications. Many of the benefits, as you would expect, start coming back up in terms of either weight or waist circumference or cardiovascular benefit. And it really begs the question, if you and I and medicine in general should start thinking about how we counsel people around, stopping these medications, particularly if they're at cardiovascular risk.
Yes. So this is not coming off of a cardioprotective medication, a medication that provides significant metabolic benefits. This is not a cosmetic issue. This has nothing to do with how well your clothes fit. These are medicines that, in many cases and in many different trials, have been shown to significantly reduce the risk of major adverse cardiovascular events in, for example, people with type 2 diabetes at high risk for such events, and people with overweight or obesity who have established cardiovascular disease. So these are drugs that have shown a benefit, and we don't think that that benefit is only because they help people lose weight. It's probably far more complex and effective. So we know that when you take the medicine, it helps to reduce the risk of these serious adverse outcomes. And when you stop the medication, again, we know that people on average tend to regain weight. Their control of their cardiometabolic risk factors tends to deteriorate. And we would assume that along with that, the cardioprotective benefit of having been on those medications will dissipate. And there are data to support that now.
No, I
Um,
agree with you completely. As a heart surgeon, and for those listening, if you've got a heart condition or you live with high blood pressure or you live with high cholesterol, and I think this is something that you and I have spoken about in the past as well. If you're taking a medication for high cholesterol to reduce your cardiovascular risk, you take it long term. You don't stop it, because when you stop it, you would expect the cholesterol would sort of creep back up. The same thing with blood pressure. You stop blood pressure medication, your blood pressure goes back up. So, I think you've said it really well, Dr. Green, and that is that these are cardiovascular medications in many cases. And therefore, if your doctor is using it for cardiovascular risk reduction, it's important to take those medications sort of long term. And it really brings me to the next question for you, that should we start thinking or counseling people in advance about long-term maintenance even before we initiate treatment? Is that conversation something that needs to occur early on?
yes, I think that is a very important conversation, even before someone is started on such a medication. It needs to be considered a long-term disease management intervention. It's not the kind of thing that it's not a crash diet type of approach. It's not the kind of thing we're generally, at least in my clinic, starting people on because they want to look good for a big event. These are medicines that I'm starting often to help with blood sugar control, but to keep people healthy, to keep them out of the hospital, to protect their cardiovascular system and their kidneys, and to help extend the duration of their lives.
Right.
And so these are very important reasons for people to start and continue to take the medications. In general, my conversations with individuals who are considering starting these medications or who are taking these medications, we're discussing the use as a chronic therapy. I will say that for someone with diabetes or high blood pressure or high cholesterol, sometimes it's really obvious to the person who has started these medications that they're helping in a lot of different ways, because I'm able to cut back on some of their other medicines for diabetes, for blood pressure. I'm sure you've seen this many times. Occasionally, medicines that they're on to control their cholesterol or triglycerides can be reduced a bit.
It can be down titrated, exactly.
It can be down titrated. And so that's something that is, I think, really concrete and understandable that a person experiences on a day-to-day basis. And if they've been able to do that, I think it reinforces the concept that this is a medicine that is benefiting them in real and understandable ways, and it helps people understand why they need to stay on it on a long-term basis. But at the same time, even if that has not been the case, for most people, these are going to be medicines that are used indefinitely.
No, I agree with you 100%. I've seen so many additional benefits when these medications are started. It's almost, it targets the root cause of so many diseases that are interconnected. And, again, people in some cases can decrease the doses of their blood pressure medication. Many people, I've seen endocrinologists decrease their doses of insulin, for example. I've actually even had a few people who've come off insulin because of access to this. So it really has in many ways, sort of a cardiometabolic reset for many individuals struggling with cardiometabolic conditions. Now, I want to ask you a personal question around surprises, serendipity, and things that still amaze you about GLP-1 therapy. Are there, it's almost like the gift that keeps on giving, as a leader in the field, are there things that still surprise you about this class?
Well, there are surprises, and I think it's important to talk about those because there's a lot in the lay press about on social media about these medications that, for example, when you lose weight on a GLP-1 receptor agonist, on a GLP-1 based therapy, you're not losing just fat. Now, it's mostly fat, but it's not entirely. And this hasn't been studied as well as it has in the clinical trials that have been completed so far. But when we look across the trials of these very effective weight loss medications, somewhere between 25 and 45% of the total amount of weight that is lost can come from what is described as lean body mass.
Oh, this is a really important topic. Yeah.
It is. And remember, though, that lean mass is not just muscle. It is muscle, but it also includes body fluids. It includes the liver and other organs.
I think that's a really important, because I always thought that lean mass was muscle mass.
Well, that's muscle mass is part of it, but it's not. So when you see loss of lean body mass in the newspaper or in a medical article, that doesn't mean that it's all muscle.
Mm-hmm.
A good bit of it is, but not entirely. Some of it, again, is just the amount of blood and other fluids in our body, and it's our organs. And some of what's being lost, for example, from the organs, is fat that is in and around some of the organs that really, for the most part, shouldn't be there. That is fat that's contributing to our risk of organ damage. So that's not necessarily a bad thing. And it can be difficult with some of the imaging tests that have been performed to assess the effects of these medications on body composition over time. It can be a little bit difficult with the types of images that we have available to really understand if, for example, the size of an organ changes, is it because, or the size of a muscle changes, is it because you're losing the cells of the organ, or is it because you're losing actual muscle, or might you in fact be losing some of the fat that is in that organ, or actually woven throughout that muscle, which would be a much less concerning feature. So that we don't know. The good news is that when it has been studied, when people lose weight on these medications, that when it's been tested in a rigorous fashion, that muscle strength, despite the fact that muscle mass may be decreasing, muscle strength seems to be, for the most part, preserved.
Right.
So that's what's most important. It may not be a terrible thing that the size of the muscles decreases as we're losing significant amounts of weight, as long as we remain strong.
Exactly.
And functional. Exactly.
I think that's so well said. It's not just about the mass, it is about the function and the strength of muscles. And I participated in a clinical trial where we were looking at people living with PAD, and they received GLP-1 therapy, and these are people with peripheral arterial disease, and we actually subjected them to constant load treadmill testing, and certainly these medications, as you said, are associated with weight loss and some muscle mass loss, but despite that, objective measures of muscle strength on a constant load treadmill work better, right, at the end. So I think that sort of speaks to what you just mentioned. So it really brings us to important practical question for people watching, and that is, what are the recommendations? What are the guidelines around preserving muscle mass during weight loss? And this is not just GLP-1, because there are many of our individual patients and others who undergo bariatric surgery. Many are losing weight just by good dietary advice with dietitians and good lifestyle interventions, and many are successful with that as well. So I think there's probably sort of some general, guidance that we can give people around what they should do to preserve their muscle mass when they embark on any strategy of weight loss.
Absolutely. So there are really two key points. And one is to make sure that protein intake is adequate. Now, I don't want people to come away from this conversation thinking that I'm recommending a high protein diet. That we'll get into the nuts and bolts of that.
Right.
But to make sure the protein intake is adequate. And then the other key part is actually resistance exercise. And these are recommendations that frankly apply to everyone. These are all good strategies for us to remain strong and healthy. But they're particularly important when someone is losing weight, particularly when they're losing a large amount of weight within a relatively short period of time. So recommendations for resistance training would be to participate in that at least 2 or 3 times a week, generally on different days is recommended, but to use the major muscle groups. And in fact, what seems to be most effective is what's described as progressive overload, where over time you're essentially lifting or pushing it against ever heavier weights or degrees of resistance. And what's really interesting, there doesn't seem to be an age limit at which people no longer benefit. There was a really interesting study of nursing home residents who were all over 90, who all participated in resistance exercise under supervision. And it was a very effective intervention with respect to measures of strength. So there's no point in our lives where it's clear that stops benefiting us.
It's interesting. Just this morning, I read a paper in JAMA Open that talks about, the importance of strength, muscle strength in women. And it talks about how muscle strength, even after accounting for, aerobic fitness, for example, and all of the other things, was associated with a 30 to 35% lower risk of dying from any cause. So I think your message is spot on, and that is that regardless of whether you're embarking on a weight loss regimen or not, preserving muscle strength with resistance training cannot be overstated. So really, as we bring this to a close, you've been a friend and a colleague and a real leader and a maven in the field, Jennifer, and really we would like you to sort of help us understand, or help people listening understand, what is it about obesity that we are now seriously beginning to understand?
Well, first, we need to understand that obesity is not an issue related to willpower. It's not a short-term problem. It's a chronic, biologically regulated disease over which we have some control, but we certainly cannot control through willpower or our best efforts. And I think people with these conditions have always known this. But it's been difficult until recently to address this condition effectively. But now the science is catching up, and we have extremely effective medications that can work for many, many people affected by overweight and obesity. And we're moving away from thinking about weight loss as a short-term goal, as a cosmetic goal, but as an effective means of disease management. Thinking of more from moving from short-term goals to really long-term, a lifespan or life health approach. And again, there's really no value in blaming people for what they weigh. Weight is again a very complex biology, and now rather than assuming that it's a problem that people should just deal with on their own, we have many effective tools. And all of us who are caring for patients should be ready to have those conversations and willing to offer what's now available.
Well, this has been wonderful. It's been great speaking with a real luminary in the field. What is becoming clear is that GLP-1 based therapies are much more than weight. They're really agents that are at the root of cardiometabolic risk reduction. We've learned a lot about how to stay healthy on these medications, and really how to incorporate GLP-1 based therapies as really chronic disease management tools, understanding how to start them, how to stay on them, how to take care of muscle health and muscle strength. But most importantly, colleagues, is the fact that overweight and obesity is something neither patients nor doctors nor healthcare professionals should stigmatize. We have to, as a community, recognize that the stigma around obesity still persists. And it is not a failure, as Dr. Green and I have said. It's not your failure. It's multifactorial. And we all have to come together as a team to help empower individuals to be successful on their journey as it relates to chronic weight reduction, but also chronic heart and blood vessel protection.